I'm going to talk unusually now, because at most meetings I've not taken the opportunity to talk, but I felt it was important because, partly because of the environment we are within the NHS at the minute, it's a stage of continual churn. There's a lot of things happening from policy level down to change, if you like, at ground level. And that makes it quite difficult. It makes it very difficult to actually sustain things, and it makes it particularly difficult if we don't plan to sustain events. Again, you've seen us use this slide before about what happens to, and not just improvement projects, any sort of change thing, whether it's in health or non-health. This applies out with health. But the fact is, if we're trying to change something, on average, about a third are successful. That means 2/3 are not successful. And when we even look at a third, Class C there is good to get somewhere and then maintain it. And that may be appropriate for a year, 2 years, 3 years. But at some point, it will almost need, again, to morph. So the fact that we reach status quo is good, but then at some stage that will need to accelerate. So Class A and Class B are really what you want, are closer to what you want, because it's more like a continual learning process. And we know that the NHS suffers from projectitis. What does that mean? We do a project, we get a team, they do their work, you then take that team and move them somewhere else, and you wonder why what's gone before hasn't actually sustained, or it's only sustained at a slightly lower level. So we need to get a little bit slicker about building capacity for change. And again, that's partly what the Clerk is aiming to do. So we want all of the work that you're doing to be in Class A, B, or C. That's what we aim to do. And if we can't help you get there, then it's our responsibility. We have a responsibility to support you reach those goals that you have. I was looking at sustainability again, and if you go to look at sustainability, and there's a number of definitions of it, and I've just taken this from a paper in 2008 that Laura's already used to influence what she's doing, but I just highlighted it. A lot of it's around time. So actually there is a period of time where things go on and they continue to happen. There's something around them becoming part of routine work, institutionalization or integration. And there's certainly something about them being capacity building in terms of human resources or other resources. So all of the definitions that sit there say something around this needs to last, it needs to become embedded, and the individuals and organizations need to be part of that capacity building process. So sustainability isn't easy, okay? And again, when you're talking about sustainability, what do we mean? What does the government mean when it talks about sustainability for the NHS? It's possibly not the same thing as the person who's on the shop floor delivering care. They'll have a different view of sustainability, and that's one of the problems with the words that we use in health. They have different meanings in different contexts to different people at different times. But whatever it is, staff, patients, and carers at the bottom line, if they're not involved in the process, there will be no sustainability, because they are actually the delivery units that make the difference. And going back to the government view of the system, if you look at a lot of sustainable papers, actually what they're really talking about is environmental and green energy saving. That's a lot of the literature, even in health, is around how do you make your organization green, particularly from America. So the environment side is around that, but that environment needs to be broader than that, and I'll come back to this in terms of supporting staff, what's the environment for patients. It's a much stronger thing than just greening. And so therefore it is a very complex thing to look at. So what we've talked about, and as you know from the work that we've done, is we've moved away to some extent from the concept of sustainability, which actually does mean a lot of different things to different people, to actually the concept of long-term success. And that again has come from you with work that Laura and Cahal have all done, assimilating the feedback that you've come up and said, actually these words don't mean something. They certainly don't mean a lot to people who are on the front line. How sustainable is your department today? I'm not sure. So what does success look like, and how do we deliver success? And a lot of the things that are in there are around how do you create communication, but you need to start planning for sustainability now and then continue to look at how sustainable are the processes and systems that we've put in place. So going back to Julie's paper on PDSA, some of this is hard work, but the investment in this sort of work is the thing that pays off in the long term. Again, too often in healthcare, what we do is we start running before we can walk. So planning what we're doing, understanding what we're doing, measuring it qualitatively or quantitatively, applying methods as best we can to understand it, actually is more likely to deliver success. Now, I'm not sure if there's anybody from the commissioning side in the room at the morning. Is anybody from commissioning? No, Okay, NHS London's going to get about 300, people are nodding vaguely. NHS London will get about 300 million this year from March onwards to support transformation, etc. as an additional, well, potentially as additional money, depending on how you do your accounting. But it's built up, the plans are called sustainability and transformation plans. Now they're powerful words, we've just said, but for many people, what does it actually mean? But where I have difficulty with this is that if you look at the one-year operating plan, it says reconcile finance with activity, so we know value and money is important in healthcare. The next one is demonstrate planned contribution to efficiency savings, which sounds a little bit like money again to me. And present plans to deliver the must-dos, whatever the must-dos are. And we're going to look at how quality and safety will be maintained and improved. Surely that's not an ambition. Okay? And yet that's what's being put out through the chief executive systems as we speak at this point in time. So it's important. And of course, if you go back to Don Berwick, and I actually did go back to the original paper, because I think it's always quite interesting to go back to the original paper and say, what did he say, as opposed to what have we paraphrased over time. I also thought it's quite useful to acknowledge there was a couple of other people who were involved in writing it, just because we tend to talk about the Berwick paper. But the three aims in the triple aim were improving the individual experience of care. I'm going to come back to that, of course, within the Clark programme, involving patients and carers as early as we can and throughout the programme is part of what we're aiming to do. So that we would have that as an ambition. Improving the health of populations, again, within the Clark programme, you will define a population, whether it's a very small population or a big population, doesn't matter. You'll define a target audience for your programme of work. And yes, there is reducing the per capita costs of care for populations in what was said. And of course, that is true. We have a responsibility, certainly in the NHS, to spend money wisely. That would be inappropriate if we weren't spending. But they are all interdependent, and none of them are actually taken individually. But there's a bit in the work, in the literature, beginning to go on the bottom bit, about the health workforce reports increasing burnout and dissatisfaction. Now that may reflect a whole variety of things, but I suspect that for most people in the room that would be what you would be picking up if you were just feeling the mood music of health and care in the UK as we sit. But we also know increasingly from research that if the staff are not feel valued, that you're likely to get reduced patient satisfaction, reduced health counts, and actually may paradoxically increase costs. So there is something that people have now called the quadruple aim, which is providing a better experience for health and care professional, and that's at a team level and an individual. And again, going back to the programme and what you're doing, you are working in teams, and it's teams that deliver healthcare. Now, I'm just going to go back to this to be fair to Don Berwick. And he doesn't say it in the paper. Maybe his first point actually did mean staff as well, but it's not articulated in the paper, if you know what I mean. But this is a partnership. It's healthcare professionals, or health and care professionals, patients and carers working together. But I think we've reached a stage where if we ignore the staff element of this, we do it at our peril. And again, just a little bit in terms of what organisations do is actually what often happens when you're doing changes, we put more checks and measures in. And the more checks and measures we put in, that's the way we think we're controlling the system. Whereas actually what we need to do is improve processes. And Andrew Lansley didn't like the word process. He thought everything had to be outcome driven, but actually outcomes only come by getting the process right, that process of care. And of course, a lot of work that you're involved in currently as individuals or as part of your teams or even in your day-to-day job is actually looking at how can we improve process or the process of care. If we get that right, we're likely to get the outcomes, including experience, right for staff and for patients. So there are some preconditions that Don Berwick has in his paper. So one is include the enrolment of an identified population. So in terms of the work that we do in the Clark, can we define the population? And by that, it's not just the population that we want to make better or interact with. It's the team that work around that, I believe. It's a commitment to universality of its members. So equality of access, equality of thought, equality of opinion. That's something that we need to engender in the process. And again, I would argue that when Laura comes to talk about the long-term success tool, one of the things you're doing is create a conversation of equals. And the existence of an organisation, you can't do this without an organisation, but an organisation has a number of things. An organisation is quite amorphous, so what in the organisation is actually making these changes happen or supporting these changes happening? So in a healthcare organisation, what happens within the organisation or in a care setting? But equally, you could argue that Clark is part of this integrator function. We have a role, we've got expertise, but as I said earlier on, with that comes responsibility. And we need to take the responsibility for sorting out and supporting issues where there are challenges and encouraging people where they've got difficulties with some of the ideas we're coming up, challenge them. We need to support people through that. And all of that is related, if you put it down into a nutshell for Don Berwick's work, is actually closing the translational gap. Can we get best practice into routine practice most days of the week? That's what we're aiming to do, whatever we define as best practice. So I'm going to be slightly critical here at the minute, but just to put it in context. In the paper, they talk about patients with heart failure. Now, heart failure is one of the projects that we work on within Clark, but actually we're thinking beyond heart failure. We're thinking much more of comorbidities as that part of the process, but we recognize heart failure is a significant condition for the patients, for the carers, for the healthcare system as a whole. So that's an issue in the UK. And in 2008, they said, well, 40% of patients from Medicare, the discharge, were readmitted within 90 days. In that paper, they make a really strong assertion. They say that could be reduced by 80%, which roughly means around 8%. Tom, correct me when I get that wrong. But they're saying, they're implying really a pretty massive change in reduction, depending on how you do the calculation. But they're implying it's very significant. Now, if you then go to the United States data, and this is now not 90-day readmission rates, this is now 30-day readmission rate, looking at heart failure. Effectively, the situation's been pretty, and again, they've done a really bad thing here, because actually they've got this graph starting at 15, which makes the relative change look better. It's a standard trick, but it's a trick. But the reality is there's been something possibly happened in all of this in between 2.8 and 2.11, but it's not huge. It's definitely not huge. And in fact, what they did in 2000 and, I'm going to get the date wrong now, 2012 is they introduced a punitive system such that if people were readmitted in healthcare in the States, then the provider organization lost money. Okay? So if you then move on and look to what's happened over that period of time, there has been no shift in heart failure readmissions in the United States, according to the national data. So the mean remains 22%. Some organizations are doing better, some organizations are doing worse, but that's what they were doing before. There was a spread, there's naturally a spread. I think part of the problem for this is they don't have an integrator, they've not got a project or a plan that's saying, how can we look at this in a bigger picture? They've got lots and lots of ideas, if you read the literature, but they're not coalescing into something that's actually delivering integrated care for patients with heart failure. And they've not looked at the thorny issue of comorbidity, which again, all of you who are practicing know that most individuals have more than one condition at any one time. So that's really important. And what happens if we don't do that? You get fatigue, staff get fed up. We say, well, we've tried that before, it didn't work, why am I going to try it again? Patients have come along and tried to help and said, well, we've tried to help, it didn't work, why should I do this again? So we need to understand that the cost of failure is actually very significant in terms of human behaviours, human cost, and indeed finance. So going back to the sustainability and transformation plans, maybe they need to turn it around the other way and say if we deliver a high quality service, we might actually deliver some cost savings and we might improve staff morale and we actually might deliver patient benefit. And I think if we don't get the language in the right order, it will remain problematic. So we don't want to get to that sort of situation. And again, this is a work that Trish and others have done at Northwick Park, but they've had, it would be fair today, a difficult journey, Trish, getting the care bundle for organisations that have used care bundles before, just getting it done. But even, saying, well, we're doing this, getting it up to the number of patients who they think should be on a care bundle from a relatively small number to a roughly 40 per month, that's been hard work, but it's beginning to pay off and people are beginning to buy into it. And the early signs are patients are doing better for it. But you didn't achieve that overnight. That required hard work, integration of patients, and indeed going back to the data. So what you want to do is make sure that we know that everybody wants to come to work to do a good job. We know they're enthusiastic. We know when people are beginning to form teams to make change, they come with different mindsets. I don't think this is going to work. I think this is going to work. I'm a bit nervous about this. I've never been in a room like this before. All of those emotions are going through our head. And therefore, it's important at the beginning and throughout any change program or project that we actually continue to recognize those different emotions and different ambitions that people have within the room. So from our point of view, and you're going to hear a bit more of this, what does long-term success for us look like? It's when it becomes normal. That's what we do. We're seeing improved outcomes, so it does need to be linked to some output. You need to know what you want, where you want to get. But it becomes part of a systematic approach, because that goes back to projectitis. If we don't systematize this, not in a kind of thou shalt do it this way all the time, but actually people see change and the benefits of change as being part of the routine job, the danger is the next project will be a new day and they'll start the whole thing from scratch rather than use the tools and techniques that they've built up over the phase. That's where we are. So what you're looking for in the diagram is a happy patient, a happy member of staff, a happy researcher, people who feel valued in the system. And if we're delivering something sustainably, and you can say, we did this, and look, the patients are better, or look, the patient experience are better, or look, the staff are happier, then you've achieved something. You've genuinely made things happen when you can stand back and reflect that that is the position that we're in at this point in time. So that's the important thing, that thinking and attitudes have changed. And that goes back to some of the definitions of sustainability that I put up in the early phase. It's not just about something keeping going. Something else has happened if you've delivered long-term success. So from a Clark perspective, we want to embed and use the tools and techniques. We want to work with you. This is Vimal's 4 seasons. There's no music about to play in the background to this, but as Vimal tried to say, this is a continual cycle that we go through, and these events are part of that cycle to try and, if you like, make sure that we get real long-term success. And part of that comes back to the work that Julie, Tom, and others have done in terms of developing a systematic approach. You've heard this before, but it is about acting scientifically and pragmatically. So one of the things we want to do is we do want people to actually use the tools and techniques with a degree of fidelity that they trust what is said and they use the challenges to take them on to the next thing. The concept that health isn't complex, where you people say you treat hospitals or as widgets or patients as we've got to get away from that. Health is complex, and recognizing it's complex actually allows us to do the job properly. It comes back to working in teams, everybody having an equal voice in a dialogue. And that, therefore, is how you engage and empower. If people feel valued, be part of the team, they will deliver, and they will deliver to the best of their ability. So that engage and empower is part of what we're talking about with long-term success. So Laura's going to pick this up. It is sitting within engage and empower, but it's also about doing it early in our thinking and then being brave enough to continually reassess how are we doing, where are we sitting in terms of our long-term success? Are we achieving what we want to achieve? And that's not just about hitting the end number, it's actually, have we built the capacity, have we changed the thinking processes? Have we made something different today or tomorrow or the day after?